Okay. Hello, everybody, and welcome to class number 9 of Ethics and Law in Psychology. Uh, Today we are going to talk about, well, today, both this lecture and the next lecture, we are going to talk about probably two of the most, if not the most important topics in this course, two of the ones that stand out as causing the most serious concerns: suicidal clients and mandated reporting. The two are almost flip sides of the same coin because uh, suicidal clients is when you're worried about a client being of danger to themselves. Mandating reporting also occurs when you're worried about a client being in danger to themselves, but more so, uh, or as much someone else being in danger, usually either a child or a dependent elderly or somebody else that a client might harm. So, um, uh, let's start by talking about suicidal clients. Now, as far as your responsibility as a clinician, if you feel that a client is suicidal, I've brought this up before. It's different requirements in different states, but for the most part, the rule is that you would be required that if you feel that a client is actively suicidal, you would be required to do what you could to make sure they are safe. And very often that means hospitalization. So, depending on whether you would be eligible, different licensing allows you different ability to have someone admitted. But um, either you would admit them yourself if you're a licensed psychologist in your state, or you would go through the crisis management agency to have that person committed. So I do think that it is. I wanted to sort of use this section to maybe not talk as much about the ethics because the ethics in the law are pretty straightforward. If you feel that a client is suicidal, um, and if you feel they're actively looking to harm themselves, you would be required to find some way to get them admitted into the hospital. So what I wanted to do, so what I wanted to do in this class is talk not just about the ethics of of suicidality, but to actually talk about evaluating suicidality. How do you determine if someone is seriously of danger to themselves? Because that ties into the ethics. Um, Not only because it is sort of the ultimate responsibility that a clinician has as far as keeping their clients safe, but because there is a real breach of confidentiality that comes up when you have someone that you believe is seriously of danger to themselves or to someone else. That's why we talk about the mandated reporting um, issue, and so it becomes a serious question of how do you determine if there is a serious enough threat of a person being suicidal and of actually harming themselves that that you break that confidentiality and bring someone else involved, bring someone else in to see if the person is actually of danger to themselves. So I want to talk about suicidality here, and then if we have time in this part, we'll talk about lethality, which means how do you determine if someone might be a danger to someone else. Uh, but let's start with suicidality. And I, as a clinician, I've mentioned here I consult to a number of medical facilities, and it's interesting that one of the most uh, uh, one of the most um, uh, common things that I get called about is to assess suicide. And what I run into at the medical facilities is the vast majority of times that I am called in, it's for someone who has said that that they're ready to die, and that or that they wish they would die. And wishing you, saying you wish you would die, or that you're and or that you're ready to die is not the same thing as being suicidal. Suicidal is an active feeling, like you want to kill yourself. There's an active component to it. Um, and saying you're ready to die is not, or even that you would like to die, is not saying you're going to do anything about it. It just says that um, if you were to die, it wouldn't uh, be something you'd be negative about, or if you were to find out that you're dying or that you're going to die, uh, which is in a lot of way healthy. I mean, we're all going to die someday, and the idea that someone is prepared for it or even ready for it may be a healthy thing. But the degree, but if they then add this part that they are going to actively do something to make it happen, is is that's where the concerns about suicide. I would even argue that the term passive suicide, their passive suicidal thinking, that even that is a misnomer, because there still is often a degree of the person planning to actively do something to bring about their death. Passive suicidal wish is the term that is often used for something like a person who says they're going to stop eating or they're going to stop taking their medication as a way of bringing about their death. It's often done as a way to contrast it with active suicide, which is uh, hang hang yourself, overdosing on pills, that sort of thing. But I would argue that even what is come to be termed passive suicidal wish is still active. Someone who is refusing to eat is actively refusing to eat. They actually are saying, I am not going to eat. In fact, you have to put a lot of effort after a short period of time to not eat because you're going to be hungry. So you're fighting the fact that you are hungry to get out, to keep yourself from eating. Okay. Um, so, um, um, so there's a couple terms to keep. Suicide is a term that is used when a person dies by self-directed injurious behavior, where they have an intent to die. So to say someone um, dies because of suicide, it means they actively were seeking to kill themselves. Suicide attempt, um, uh, suicide attempt is a potentially injurious behavior that the person engages in, um, where they where they intend to die but don't actually die because of it. Um, and uh, so suicide attempt um, sometimes can be uh, a little uncertain because sometimes suicide attempt could either be what would essentially be called a suicide failed attempt to die by suicide. In other words, the person attempted suicide, but they were not successful in killing themselves. But then there's also such a thing where a person will engage in a suicide attempt, um, um, but more so do it as a way of calling for help. So, what often happens, so that would be the distinction between what is called a suicide attempt and what is called deliberate self harm. Because deliberate self harm and suicide attempt are similar, except with deliberate self harm, there is not an intent to die. There's an intent to harm oneself, maybe even to worry other people that they're going to die, but the intent of the person was not to die. Whereas a suicide attempt is um, is a an actual in there's an intent to die. So self harm is when the person does not have the intent to die, but still has the intent to injure themselves. Suicide attempt is there had been the intent to die, but it just didn't happen. Example of the suicide attempt would be, someone tries to shoot themselves, but don't they don't shoot themselves in a way that causes death. So they may cause themselves permanent injury, uh, but they do not but they don't kill themselves. When you are assessing suicide, it can be important, it is important to distinguish between three different things: suicidal ideation, suicidal plan, and suicidal intent. Of the three, the least concerning, although they're all three concerning, but the least concerning is suicidal ideation. Having thoughts of suicide um, by itself will not usually be considered the person being suicidal. Having suicidal plan or suicidal intent can be. Uh, but if the person just has suicidal ideation, like they have thoughts of suicide, that is not sufficient in most cases to deem the person as being suicidal. People have thoughts of killing themselves much more often than they have any actual plan to follow through on those ideas. And suicidal ideation uh, is uh, suicidal ideation is having thoughts. A suicidal plan is when a person actually, as the name implies, not only has thoughts of suicide, but thinks about this is how I would do it. Um, Now, it's interesting that sometimes there can be a little crossover between suicidal ideation and suicidal plan. Example, I mean, going back to the medical facility that I'm at, in some of the longer term places where people are staying longer term, uh, sometimes suicidal ideation will be expressed with the statement, "If I had a gun, I'd kill myself." Well, that's probably more in the ideation part because the person's in a medical facility. They don't have a gun. There's no way. The place I go to, there's no way they have a gun. They couldn't bring it into the place. So, um, or, I feel like I want to jump out the window. Meanwhile, they're on the first floor. So even if they did jump out the window, nothing would happen. So sometimes there's a crossover uh, between ideation and plan. Plan has to be, in order for it to be a plan of concern, there has to be a legitimacy to the plan. There has to be a way that it actually could be carried out. An intent is where the person shows evidence that they not only have a plan, but are seriously thinking about how they might follow through. You they could talk about where they have a gun, and uh, how they might go, how they might go about using the gun. So there's ideation, which are thoughts of suicide, suicidal plans, which is if I was actually going to kill myself, this is how I did it, I would do it. And then suicidal intent is not only do I have a plan, but I am showing evidence that I have intent to follow through on doing it. Now, in the book, they gave some um, pieces of evidence that show indication that the person may be moving more towards uh, from ideation to in past plan into intent. So if the person starts talking about, I wish I were dead, what's the point? Or they show a drastic decrease in any concern about their appearance, or a drastic decrease in their mood. This is all indication that the person may be moving from ideation into plan into intent. Now, how do you tell if the person is moving into intent? That, you uh, very often, sort of the key way is, you pick up on some of the things as they're laid on the book. The person talking more about, I wish I were dead. The person showing more evidence of being drastically having a major drastic negative change in their mood, the person showing much less concern about their hygiene and their appearance. But then you would really have to pursue the question of, is this person suicidal, by talking to them and finding out if there is any evidence that they're thinking of killing themselves. Very often, the way that you assess it is from what the person doesn't say. Um, with suicide, with active suicidal individuals, it'll often be someone who's not willing to say that they are not planning on carrying through their plan. Um, People who are not suicidal will typically be relatively quick to say, yes, I have thoughts, but I'm not going to carry them out. Yes, I wouldn't do that. I wouldn't do that to my family. I wouldn't do that. I just don't have the guts to do it. Anything like that. Those are all people who are not suicidal will usually be fairly ready to make the statements like that, to deny any serious intent to follow through on a plan. Someone who is suicidal will not actively refute questions about whether they are thinking of following through on their plan. So, very often in assessing suicide, it can come along when the person is not willing to commit to a plan, or commit to not following through on their plan. One of the reasons why clinicians are often encouraged to get a client to verbalize a plan for what they will do if they actively start to have thoughts of carrying through on their plan is um, because uh, it shows that they are not yet in that area of having decided that they're carrying through their plan. Once someone is committed to themselves that they're going to commit suicide, uh, they will typically not even be willing to agree to follow through on a plan um, to get help if they become actively suicidal, because they are actively suicidal and they're not looking for someone to stop them. So, very often when you're assessing suicide, you have to watch for what the person is not willing to say. Um, if they are not willing to commit to call an emergency room if they get actively suicidal in terms of intent, that can be a serious sign that they are at that moment committed to following through on their suicidal plan. There's a bunch of statistics that you can find about suicide. One thing that I find interesting when I see it uh, uh, is more people die from suicide than homicide. I actually was not aware of that till I saw that in a series of statistics. Um, it's the ninth leading cause of death among adults and the third leading cause of death among adolescents and children. Uh, one interesting thing about suicide in children is um, the most common way that children commit suicide is they run in front of a vehicle. Um, there are other ways, but the most common way is that they run in front of vehicles. And what's interesting is when they do a suicide autopsy on children, regardless of how they committed suicide, um, there is the majority of time there is evidence that at the last moment the child tried to like they tried to change their mind, like autopsies on suicide are not common, but they are common with children because it's considered even more tragic when a child follows through on suicidal intent. And what they have found is in children the majority of the time, and in adolescents a large percentage of the time, there is evidence that at the last moment the child or the individual, whether it's a child or teenager, uh, tried tried to back out, tried to maybe um, you could sort of guess where that might be in like an autopsy. Child tries to run in front of a car. At the last moment, the autopsy finds evidence that the child tried to jump back and just didn't make it in time, or uh, someone teenager cuts themselves with a cuts their wrists, and there's evidence that they tried to stop the bleeding, um, and things like that. So child hangs adolescent hangs themselves, and there's evidence they tried to pull the rope off at the last moment. So there's a lot of evidence. One of the things that makes suicide so tragic, especially in younger groups, is that there is a lot of evidence, and in many cases the individual at the last moment tried to back out of it. um, and and there may even be evidence, and this is more up for debate, about whether some suicide may actually be self harm that went a bad direction. The most common example would be cutting. Cutting itself is considered almost entirely a self harm behavior. It's not considered suicidal. The problem, though, is the degree to which you can cut without without it being fatal is the difference between cutting that is just cutting and causing a scar and cutting that is fatal is like millimeters. Like you take a razor blade or you take something, you start cutting on your wrist, you can see, you can pretty much see the vein that you would need to get to in order to cause a fatal cut. And there's some evidence that some suicides by someone slashing a wrist, what was started off as cutting, it just went too far. Um, you know, self harm might be from pills. You think, um, how many teenagers actually know how many, uh, you know, Ativan or Xanax you'd have to take to kill yourself. Sometimes the number is, so maybe they meant to take it as a way of, uh, um, taking. Maybe they meant to take just enough to cause other people concern, and they ended up taking too much. By the way, when you talk about pills, it's also interesting that you then bring into another issue that often is involved. That's a major factor in suicide, which is alcohol. Um, Alcohol and drugs, but particularly alcohol, plays a large part in many suicides. There's a lot of evidence that at least half, if not more, of suicides have alcohol as a factor. And I brought that up with the pills because that certainly could be. A teenager may say, "Oh, I'm going to take." They may read up on it and find out, well, if I take eight Ativan or eight Xanax, eight of my Xanax, I I'll make myself sick and people get concerned, but I won't kill myself. That may very well be true, but then they down it with a couple shots of vodka. Well, that throws everything into disarray and certainly could be fatal because you start mixing medications and alcohol. Your so some things I don't want. I mean, I certainly want to talk about suicide because I don't think it's talked about much in some other classes. I think you really need to understand it in order to understand your ethical responsibilities. But pulling this back to ethical responsibility specifically, you want to know what to look for, which is the person starting to sort of slip emotionally. You want to look for the things that the person is not willing to say. You know, if a person is not willing to commit that they will get help if they are uh, following through on intent, then if they're not willing to make that commitment, then that's an indication that they've already made up their mind. A lot of times with suicide, what you're looking for is evidence that the person's already made up their mind. Someone who's thinking about suicide, someone who's even thought about what they would do, isn't necessarily an immediate self harm. It's when they've sort of moved over into they've already made up their mind to follow through on intent. That's when you really got to be worried about things. And usually you can only assess that by what they are not willing to commit to. And then you also want to watch uh, you want to watch for somebody who's looking really down and also has problems with alcohol or drug abuse because alcohol um, there's a lot of questions about that 50% or more of individuals who where alcohol was involved in the suicide, where there's some real questions of would the person have committed suicide if they weren't drunk at the time. Um, because alcohol can be the sort of um, it can be sort of the trigger that kicks the person from having thoughts and plan to intent. One of the difficulties about suicide is it can be planned out. The person may have intent and say, okay, this is when I'm going to do it. This is how I'm going to do it. This is when I'm going to do it. And, as a therapist, as a psychologist working with patients, you have that opportunity to look for it. The problem is alcohol can kick people into that intent area really quick. Um, the person's mindset when they go from sober to drunk just can kick over so quick that you want to be careful, as far as being um, somebody who is looking like they have suicidal intent, you want to try to get them to at least consider how much they're drinking and whether maybe they might want to stay away from alcohol, um, just until things get sorted out, because that can really kick things over um, into uh, uh, the intent uh, to to where they get very seriously suicidal. Okay. I mean, it's interesting to look at. One survey I saw. A couple surveys have shown that dealing with the clinician's number one fear is losing a client to suicide. And it's I haven't known many clinicians who've lost a client to suicide, but it can be real um, uh, it can be real taxing on a clinician, as you might think. Just one, not just the worry about the ethical responsibility, but just the impact of, well, what else could I have done? It's one of those things where even if there's an investigation, which there often is suicide if the person's in therapy, about uh, where maybe the clinician's cleared of having done anything wrong, there's still, the doubt that the clinician may go through as to, my gosh, could I have done something? Could I have done anything more to have helped this person? Um, uh, so it's a fear um, that that is legitimate. Now, as far as addressing it, I mean, what you want to make sure you're doing with clients where you even suspect they may be suicidal is that you're sort of upping your engagement with them, that you're making clear that that you are recognizing that suicide might be a real possibility, and that you are taking steps to make sure uh, that you are checking in with the client, definitely seeing them for therapy every week, if not more than once a week, maybe doing check ins where they call you or you call them just to make sure everything's okay. Um, if you don't feel that you can get them committed to the hospital, um, at least make it clear that you've talked to them about considering voluntarily admitting themselves to the hospital rather than having to involuntarily get them admitted. Um, uh, so you want to, as far as ethical responsibilities, you want to make sure that you're upping your contact with the individual, that you are, like I said, that you are checking in with them or giving them the opportunity to check in with you. Um, so um, and you want to document that. You want to make it clear that uh, you are that you are considering things and taking active steps to keep the person safe. And what's interesting about that is it not only meets your ethical responsibility, but the research has shown that that sort of relationship from with a therapist, that sort of connection that the therapist is actually concerned, actually helps people feel less suicidal. People who are suicidal often feel that they have nobody who cares about them. And if you are showing as a therapist um, that you are going above and beyond what might typically be expected in a therapeutic relationship, where you see the person once a week or once every other week, and then you don't really have you may not have much contact with them in between. If you are showing that you are actively upping how much contact you're having and how much more readily available you're going to be for the person, that is not only meeting your ethical responsibility, it is also showing the person that you are uh, caring about them more than they might typically, because they might say, well, yeah, you're paid to care about me. Well, that's certainly not true. We're paid to help, but helping may mean meeting with the person for a therapy session once a week or once every other week. So if you're making it clear that you are taking active steps to go beyond that, it actually can be very helpful uh, for helping the person feel uh, uh, better about things. So a couple other things that I want to mention about suicidal behavior. Um, most people who kill themselves decide at some point to kill themselves, and so it is catching them when they've made that decision before they can go on to do something about it. And again, that's why alcohol can be such a major thing, because the alcohol may kick their decision up before you can do anything about it. Um, uh, However, even people who may get kicked into that area of following through on intent with alcohol, there usually is a period of time where they've thought about it but are ambivalent about it. Like people who have thoughts of suicide but um, uh, haven't seriously thought at some point about carrying out intent are not the ones who are likely to um, get kicked into the serious intent area, even if they're under the influence of alcohol. But there are people who are suicidal. Most people have this period of time where they're much more ambivalent about it. They they go back and forth. They made the decision, then they pull back. They thought about it, they thought serious about it, and then they pull back. It's just that when you're in that sort of ambivalent area, then if you take alcohol at a certain point, it may just kick you right up there. So it's that time. It this idea of looking for signs and getting an idea from uh, uh, the person you're talking to about whether whether they've gone into that area of intent, even if they've pulled back from it. It's because most people are suicidal, make the decision to kill themselves, but it's not always like a I'm making the decision and then bam, I'm going to kill myself. It it it's still, even if they made the decision, they may pull back from it, and they may be ambivalent about it. And you want to, if you can catch them during that area, that span of time, then you really that's the area where you can really be of most help to them, because if you can catch them before they make that final decision, before they make the definite decision to follow through on it, where that span of time where the person's ambivalent, they go back and forth on the decision. That's where you're looking to catch the person before they can follow through on doing something to do it. And if you think about, I mean, as painful it is, suicide works on some level. The person may be killing themselves because they see it as a solution to intense personal pain. And it does do that. It brings about the end to the pain. Um, Not in a way that anybody would consider good, but it does end the pain. So you're looking to help that person find some other way out of the pain. And sometimes people need time away. They need to be in a hospital. They need sometimes just to where where they're watched so that suicide isn't even an option. Because when you're, if you think about it, the biggest role that a psych hospital stay has for a suicidal patient, suicide is off the table. As much as you think you want to kill yourself, you're not going to be able to do that here. We're going to be watching you 24 hours a day. We're going to make sure you don't have any way of killing yourself. You could argue if someone uh, um, you could argue that someone who's definitely suicidal might still find some way of killing themselves in a hospital. I guess that's an argument to make, but for the most part, psych hospitals are set up to take suicide totally off the table. It's the one option that's not available to you. So where that goes is it's important to keep in mind that suicidal, you couldn't even necessarily say that suicidal people want to die. What they want to do is end their pain and suffering. They just don't see any other way uh, to do it. Uh, so um, uh, it's um, it's important to recognize that the person, when they are suicidal, when they have suicidal intent, they are seeing it as a solution to a problem. We would all agree it's not a good solution, it's not an acceptable solution, but it is something they're seeing. And so, as you're helping the person with suicide, you're trying to help them find other ways out of this pain rather than suicide. Um, okay. It's also important. One other thing from an uh, uh, ethical point of view is there's no research to indicate that asking about suicide leads a person to think about suicide. Clinicians will sometimes talk about uh, that as being a concern. You know, if I ask someone who might be suicidal if they are suicidal, am I giving them the thought about being suicidal? And there's no evidence for that. There's no evidence that asking about suicide uh, does that sort of thing. Uh, so, also, it's interesting to keep in mind that as much research as there has been done on suicide, there is no clear set of circumstances, any clear set of variables that help accurately predict uh, who is going to attempt suicide and who isn't. I mean, there are signs to look for, but as far as being clear about what sort of characteristics most consistently identify someone who is seriously suicidal, there is no set of variables. That's why looking for the signs can be so important because there's no other way to easily predict if a person's going to try to commit suicide. Um, so, what leads, you get 20 people, all of whom are suffering stressors and difficulties coping. One of them becomes suicidal, the other have suicidal thoughts, maybe, uh, but no intent to carry it out. There's no set of variables that help you um, identify um, uh, who that one person who's going to follow through is going to be. So uh, it's also important to keep in mind that the most common emotion related to suicide is hopelessness and helplessness. So it's not just depression, it's not just sadness, it's it's having a feeling of hopelessness that they've given up any hope that something's going to get better, and that's probably one of the most um, important things to keep in mind, sort of overarching about suicide, is it really is a sense of hopelessness and helplessness. So you want to look for that. It's not only the person being distressed about things that are going on, it's not only the person being concerned about what's happening. It's really a sense of this will never get better. There is nothing that's going to help this get better. Nothing I can do, nothing you can do, nothing anybody can do is going to make this better. Uh, some protective factors. So, from an ethical point of view, what you're trying to do for the person who's having thoughts of suicide, maybe moving into the plan, thoughts, plan, intent, moving into the plan, you want to try to help them with protective factors, with coping skills or environmental changes that can help protect them against becoming more suicidal. And some of the protective factors that fall in that category of social supports. That's why you being made more available to the client can be so important because you're providing social you're recognizing that the person is having more social support because you're providing more social support. You're providing more um, emotional support for the individual. Helping the person be cognitively flexible, meaning working with them, this whole idea in cognitive therapy of all or none thinking or catastrophic thinking. That's all or none. It's black or white. It's all this or all that. Things are either all good or they're terrible. And and recognizing that almost everything in life is a mixture, is some form of gray area. Helping the person recognize that it's not necessarily all good or all bad, that there's a lot of stuff in the middle um, can be important for protecting a person against becoming more suicidal. Being in treatment, and treatment could be, um, well, you would hope if someone is at risk for suicidal that they are getting both therapy and on medication. Having both is very important. Um, Being physically healthy, now that's not always something you can control, but being physically healthy is actually being uh, it has a strong protective factor against suicidal, and then working with the person to be hopeful that things could get better, even if they don't see when that's going to happen. Um, uh, that uh, that feeling that it's at least a um, that at least it's something. At least at least there's a possibility that things might get better. So helping the person feel some sense of hope and helping the person obtain more social support, have more connection with people out in the community are some things that you can do with as a therapist with somebody who's suicidal or that you're concerned might be suicidal to help move them away from becoming more suicidal. Um, okay, so to approach suicidality and suicide assessment in an ethical way, you want to make sure that you are doing as thorough a suicide assessment as you can do. So I want to talk some about suicidal assessment. Um, when you enter into a suicide assessment, when you're assessing someone that you think may be suicidal, you want to make sure that you are going in with a strong appreciation of the complexity of suicide and how there can be a lot of contributing factors. You want to conduct a thorough mental health examination, and you want to try to identify if any of the things that put the person at risk are things you can do something about. When I mentioned the protective factors before, the person being physically healthy isn't necessarily you're going to be able to do anything about at that moment or at all. uh, just off the top of my head where I've seen a lot of or more situations where there's been a real serious concern that the person is suicidal. It would be when someone is diagnosed with something like multiple sclerosis or Alzheimer's disease, and they're at the early stage, so they don't know what the future holds for them, but from what they've seen about what MS or dementia, Alzheimer's disease does to people, they know it's not good. So um, you may not be able to do anything about their being physically healthy if they've just been diagnosed with a severe uh, medical condition. And they, they may see problems on the horizon. But so being physically healthy may not be something you can do something about for the individual, but lack of social support, feelings of hopelessness, um, those things, getting, being getting treatment both in terms of therapy and medication. Those are things those are protective factors that you might be able to improve. You might be able to move the person more into those areas. Um, you want to ask specifically about suicide. You want to ask about suicidal thoughts, suicidal plans, suicidal intent. And you want to use all this to help you determine if the risk of suicide is low, uh, um, moderate, or high. Um, and so you also want to ask about things like firearm access. If the person has access to guns, you want to find out if they are being the victim of abuse or neglect, or if uh, also uh, one thing that's very useful to keep in mind is any prior suicide attempts. With all types of harm, whether it's self harm or harm to others, one of the most one of the clearest uh, predictors of whether a person's going to try to harm themselves or harm someone else is if they have any history of doing it before. Also, you want to ask about family history of suicide. Family history of suicide um, are is also commonly associated with someone being more likely to seriously consider suicide because they've seen it as a legitimate solution to ending psychological pain, which is ultimately what suicide's about. Some areas to keep in mind to evaluate in a suicide attempt: psychiatric illness, um, history, again, prior suicide attempts, history of self harm, family history of suicide, individual strengths and weaknesses, how how well do they tolerate psychological pain, how well do they cope with things, what has their response been to stressors in the past. Then you want to look at their psychosocial situation, any recent changes in stressors that they're facing, quality of social support, religious beliefs. I've known a lot of people who, because in the medical facility, a lot of patients I work with those who are older, so it's not even like their family is still dependent on them, whose only reason, I know the only reason that they haven't killed themselves is they believe it's a sin and that they won't go to heaven because of it. I'm not writing out. That's like it. That's their only reason for not killing themselves. So you want to tap into religious beliefs. You want to get a sense of not only are they having um, religious beliefs, but can you prop that up? If religion, like I said, for many people, religious beliefs are the only reason they're not killing themselves. You don't want them to lose that. You don't want them to start doubting that. Then, so you want to see what religious beliefs are playing a role, and is there a way to prop that up, even if you don't necessarily feel that's your place? If the person is of a certain religion, and you can find a pastor or a priest or uh, a, a rabbi or uh, any other religious uh, person that they would associate with, who could maybe help build that part of their psychosocial situation up. Um, you want to ask about, and then you want to ask about past and present suicidal ideation, plans, behaviors, intent. What method would they use? Um, what reasons do they have for living? You want to ask about, and you want to ask about substance abuse. So you want to get information about all those uh, areas, um, to start getting a sense of what stressors they have, what coping mechanisms they have, and whether there's anything in their history to suggest they're a danger to take suicide as a serious possibility. Um, so just to distinguish the different risk categories, um, baseline, this would be someone that you're not worried about at all. Would be someone who's not experienced a crisis at the moment, doesn't have stressors. So even if they're having and are only having ideations. Um, so if all they're doing, so even if they're depressed, baseline would be someone who maybe is still depressed but is only having ideations. So you're not really that concerned about it, because and there's no major change in the stressors that they're dealing with. Acute would be when the person is experiencing a significantly major change in the stress they're experience, uh, and then are are not only having ideations but also talking about plans, make it clear they're thinking about plans. So that'd be kind of acute. You'd start to get worried about this. Um, uh, Chronic high risk would be, or I'm sorry, no, moderate risk would be somebody who's got um, uh, a plan, pretty serious ideation, like their ideation is rather detailed and could fit. So it's not um, it's not like, well, if I was going to kill myself, I'd take 20 pills of a prescription medication when they have no prescription medication. This would be moderate, would be someone who's got ideation, and their ideation is around, I mean, it's ideation and plan, and the plan is around something that actually could happen. And then high risk, severe risk is somebody who has ideation and is serious intent. And serious intent would come from uh, you would assess that, like I said before, sometimes in what the person is not saying. If they are not willing to say that they are not going to do something, if they're not willing to commit to seeking help, if they are uh, if they are feeling actively suicidal. Just last thing, some ideas about motivational interviewing. This is considered a particularly good uh, method of interviewing clients who you think might be um, suicidal. Uh, you so some just aspects of the type of interview style is, you want to avoid confronting the person too much. You want to allow them to talk about what's happening, but you don't want to question or challenge things they're saying, even if they're talking about how they think suicidal might be acceptable. You want to express empathy through reflective listening. You want to support anything they say that could be considered optimistic, whether they're talking about something that's optimistic or whether they're at least not disagreeing with something you're saying that might be optimistic. Um, if the person is um, resistant to any sort of help, uh, again, you don't want to confront it. You want to just roll with it and allow them to express their resistance without you making it seem like you're arguing or challenge what they're doing. And then you want to talk to them about values and goals in their life and how, maybe talking about suicidal plans doesn't really seem to fit with any goals or values that they have. Like I said, this is where religious values can come in, or goals for their life can come in. All those are factors that that can play a role if you can point out how what they're saying they're hoping will happen, or what they're saying their goals are for their life doesn't fit with them talking about ending their life. So you're not arguing with them, you're just pointing something out, how they seem to be coming at it from two different areas. Okay, that's a good summary of different things to consider with suicide. I did not get to mandate and reporting here because, I wanted to cover as much as I could about suicide because it's an extremely important thing, and I don't think it's covered enough in other courses. So we'll leave it there, and then we'll pick this up at the class on Friday. I will see you all then.